Hello, I am glad to be a part of the event dedicated to such an important and unfortunately not such a rare pathology as neyroendocrine tumors. And today I want to present for you place of m-TOR inhibitors in treatment of this nosological form. So let's start from the basics. Neyroendocrine tumors, it's neoplasm of the diffuse neuroendocrine system, which is located in different organs, in acute cells. Acute cells synthesize and secrete structurally related peptides and bioamines, which are converted into neurotransmitters and hormones by decarboxylation. First articles about neyroendocrine tumors we can find in the end of 19th century in medical journals such as Lancet, but the official history started in 1907 from Siegfried Obendorfer and his report about carcinoid tumors. So he is also an author of this term carcinoid. And about contemporary history of NETs, we start to talk in 1960s with Professor Anthony Guy Everson Pierce and his acute concept. About classifications, one-third of NETs are bronchopulmonary, 2/3 are gastroenteropancreatic NETs. Also, we have classification about the region from different parts of the embryonic intestine. We have foregut, midgut, and hindgut. And this is important for proper diagnosis and in future for proper treatment. 2 years ago, a European Neuroendocrine Tumor Society with American Joint Committee on Cancer presented new classifications. New classification of NETs regard from differentiation, grade, mitotic rate, and Ki-67. It's also very important for proper treatment. Also, we have in gastroenteropancreatic NETs, we have non-pancreatic and pancreatic, and between this, we have functioning with symptoms or non-functioning silent NETs. Functioning endocrine neoplasms of the pancreas often is insulinoma, almost 40%. Unfortunately, half of patients have metastatic advanced stages. Half of them have regional spread, and half of this group have distant metastasis. What about symptoms? Carcinoid syndrome is symptoms of functional NETs. It's a systemic symptoms that are caused by an excess of biogenic amines, peptides, and other factors. Often it's flushing, diarrhea, sometimes carcinoid heart disease. Rare, it's pellagra, intermittent bronchial obstruction, and rare but potentially fatal complication, it's carcinoid crisis. It may cure spontaneously or may be precipitated by anesthesia, chemotherapy, infection, stress, catecholamines in the patient's food, tumor manipulation or embolization procedures. Symptoms include prolonged severe flushing, diarrhea, severe dyspnea, peripheral cyanosis, and sometimes even hemodynamic instability. Appropriate precautions include immediate therapy and close monitoring before, during, and after surgical treatment. In diagnostic algorithm, of course, we're interested in imaging results, histopathology, and biochemical markers. In NETs specific diagnostic, it's Octara scan, Gallium PET CT, also is useful CT MRI, endoscopic ultrasound, and single photon emission computed tomography. Histopathology give us answers about morphology of the tumor, its differentiation, specific phenotypic markers like chromogranin A, synaptophysin, also Ki67 and quantity of mitosis and other molecular markers. Specific biochemical markers for NETs, it's serum chromogranin A, urine 5-indolacetic acid, and specific substances which characterized specific functional syndromes. Of course, we need interdisciplinary approach in treatment of NETs. First of all, it's surgical intervention. Also, we can use liver-directed therapy like transarterial embolization, transarterial chemoembolization, radioembolization, radiofrequency thermal ablation, and for advanced stages, we have systemic therapy. It's somatostatin analogs, it's polychemotherapy, it's target therapies like m-TOR inhibitors and tyrosine kinase inhibitors. It's immunotherapy and the peptide receptor radionuclide therapy. As you can see, we have many options that are important for the doctor, for our patients. And first of all, we have to know exactly histopathology, imaging, functionality of the tumor, extent of the disease, tumor growth rate, performance status, family anamnesis of the patient, and availability. m-TOR inhibitors. It's a kind of target therapy of the NETs. There are a class of drugs that inhibit the mechanistic target of rapamycin, m-TOR, which is a serine threonine-specific protein kinase. m-TOR regulates cellular metabolism, growth, and proliferation by forming and signaling through two protein complexes. It's m-TOR C1 and m-TOR C2. The most established m-TOR inhibitors are so-called repalex, rapamycin and its analogs. In 1980s, development of therapeutic branch of the National Cancer Institute evaluated rapamycin and discovered it had an anti-cancer activity and was non-cytotoxic, but had cytostatic activity against several human cancer types. The development of rapamycin as an anti-cancer agent began again in 1990s with the discovery of temsirolimus. These repalex include temsirolimus, everolimus, and ridaforolimus, which are being evaluated in cancer clinical trials. So one of m-TOR inhibitors that we use in treatment of NETs is everolimus. During 2009 and 2011, the US FDA approved everolimus for the treatment of advanced renal cell carcinoma, for subependymal giant cell astrocytoma associated with tuberous sclerosis, and pancreatic NET. During these 2 years, it was also approved without the European Union for advanced breast cancer, for pancreatic NETs, for advanced renal cell carcinoma, and also for giant cell astrocytoma. During summer 2012, it was approved for advanced hormone-positive, HER2-negative breast cancer in combination with endocrine therapy. Another m-TOR inhibitor that is useful in treatment of NETs is sunitinib. In November 2010, sunitinib gained approval from the European Commission for the treatment of unresectable or metastatic well-differentiated pancreatic NETs with disease progression in adults. In May 2011, the United States FDA approved sunitinib for treating patients with progressive neuroendocrine cancerous tumors located in the pancreas that cannot be removed by surgery or that have spread to other parts of the body. So you can see that indications are wide enough. All of them became reality for patients with NETs after receiving successful results of the following studies. One of them is RADIANT-2. It's a phase 2 double-blind placebo-controlled trial. Where randomized patients with advanced NET and a history of secretory symptoms. The group A received everolimus and octreotide LAR. The group B placebo and octreotide LAR2. You can see on the graphic advantages of combination therapy, everolimus and octreotide. Disease-free survival in group of everolimus plus octreotide LAR was 16.4 months, and in group with placebo 11 and 3 months. You can see that the difference was almost half of a year. It's very important for our patient, you know this. The study RADIANT-3, the largest phase 3 trial in the treatment of advanced progressive pancreatic NET. The group A received everolimus. The group B received placebo, both in conjunction with the best supportive care. 73% of patients crossed over to group to everolimus from the group with placebo. And you can see that, and you can see that progression-free survival in group of everolimus was 3 times bigger than in group with placebo. So everolimus in combination with octreotide LAR significantly increased the progression-free period by more than 5 months in patients with metastatic NETs compared with placebo plus octreotide LAR. Statistically significant improvement in progression-free survival from 4 months in the placebo group to 11 months in the everolimus group. Based on data from the RADIANT-3 studies, everolimus is approved in the US and Europe for the treatment of metastatic highly differentiated NETs on the pancreas and lungs. RADIANT-4, a phase 3 randomized multicenter placebo-controlled trial, which was performed in 25 countries of the world to evaluate the efficacy and safety of everolimus in patients with pulmonary and gastrointestinal NET who progressed on prior somatostatin and Alex therapy. So the first group received everolimus, the second only placebo. They were treated until progressive disease or intolerable adverse events or consent withdrawal. So the results were that 52% reduction in the relative risk of progression or death with everolimus versus placebo. Based on this data of these studies, European Neuroendocrine Tumor Society approves indication for treatment in their consensus guidelines for the standards of care in neuroendocrine tumors. In gastrointestinal NETs, everolimus can be used as a second-line therapy after ineffectiveness of somatostatin and Alex, or as a third-line therapy after ineffectiveness of target radionuclide therapy. Combined therapy with target drugs with somatostatin and Alex with an antiproliferative purpose is not recommended in the treatment of NETs without functional activity. m-TOR inhibitors are both approved antiproliferative therapy for progressive pancreatic NETs and are one of the treatment options that are preferred between somatostatin and Alex and systemic chemotherapy. May be considered first-line therapy if somatostatin and Alex are not indicated and systemic chemotherapy is not required. m-TOR inhibitors are recommended for pancreatic NET after failure of somatostatin and Alex or chemotherapy. The same recommendations we can find in the NCCN guidelines version 3 2021 of these recommendations of this year. You can see that for local regional advanced disease and or distant metastasis of the gastrointestinal NETs of gastrointestinal tract, grade 1 to lung and thymus, the preferred regimen is everolimus, m-TOR inhibitor. The same situation in treatment of locoregional advanced disease and or distant metastasis of pancreatic neuroendocrine tumors grade 1-2. In preferred regimens, we can find both of m-TOR inhibitors, everolimus and sunitinib. Also, I want to remind you that our patients are not alone. They have International Neuroendocrine Cancer Alliance. In November, they celebrate their NET Cancer Day. They celebrate their victory over the disease, and I hope that our good medical practice will have good results in treatment of our patients. And I want to thank you for your attention.